welcome. I'd like to welcome all of you on the call, on the webinar, who's joining us to talk about the Physician-Focused Payment Model Technical Advisory Committee. My name is Dr. Jeff Bailet. I'm the PTAC Chair. I also have joining me as co-presenters Elizabeth Mitchell, who I will let introduce herself. She's the PTAC Vice Chair, and we also have Dr. Robert Berenson, and he's going to be co-presenting with us as well. So I turn it to Elizabeth to introduce herself.
Thank you, Jeff, and hello, everybody. Thank you for joining. My name is Elizabeth Mitchell. I'm the President and CEO of the Network for Regional Healthcare Improvement, and get to Vice Chair the PTAC, and look forward to sharing our progress to date and hearing from you about what would be most helpful. Bob?
Yeah, hi everybody. I'm Bob Berenson. I practiced general internal medicine for many years, and I'm currently a fellow at the Urban Institute. I guess it's relevant to say that I worked at CMS for 3 years on payment policy, so have some appreciation for some of the challenges CMS has, and was also the Vice Chair of MedPAC for a number of years. So look forward to the presentation.
Thank you, Bob. And as I said, my name is Jeff Bailet. I'm an otolaryngologist and the president of Aurora Healthcare Medical Group in Wisconsin, a group of 1,800 multi-specialty physicians, and also have the pleasure of chairing the PTAC committee. And we're going to go ahead and start with the presentation, and when we get to the end of the presentation with the operator's assistance, we will then start to open it up for questions and comments from all of you. So with the help of our bipartisan legislation, the repealing of the sustainable growth rate for Medicare, that formula happened in April of 2015 with the formation of the Medicare Access and CHIP Reauthorization Act. This really did start the path for changing how Medicare rewards clinicians to move away from fee-for-service to drive towards value over volume. They also created the Merit-Based Incentive Payment System, MIPS, that streamlines 3 previously separate payment programs, Physician Quality Reporting, or PQRS, Value-Based Modifier, and also the Medicare EHR Incentive Program. These provide bonus payments for participation in eligible alternative payment models, APMs, and Section 101E1 creates the Physician-Focused Payment Model Technical Advisory Committee, which the 3 of us participate. Highlights of MACRA. The repeal, as I said, of the SGR, streamlining of the multiple quality programs, as previously noted, into the new Merit-Based Incentive Payment Program, or MIPS, and it provides payments for participation in alternative payment models, APMs. So you can either participate in the MIPS system, or you have the option of qualifying for an advanced alternative payment model, which we will talk about. And that's a better, smarter Medicare for healthier people. One of the goals is to pay for what works to create a Medicare that's enduring and sustainable, and also has health information needs to be open, flexible, and user-centric. How does MACRA provide additional rewards for participation in alternative payment models? Most physicians and practitioners who participate in alternative payment models will be subject to MIPS, as I've said, and will receive favorable scoring under the MIPS Clinical Practice Improvement Activities Performance category. Those who participate in the most advanced APMs may be designated as qualifying APM participants, or QPs. As a result, QPs will not be subject to the qualifications of MIPS. They will receive a 5% lump sum bonus payment for years 2019 through 2024, and they will receive a higher fee schedule update for 2026 and going forward. PTAC statutory charge. The Physician-Focused Payment Model Technical Advisory Committee, or PTAC, was created, as I said, under MACRA. The purpose of the PTAC is to review proposals submitted by individuals and stakeholder entities for physician-focused payment models, or PFPMs, and to provide comments and recommendations to the Secretary of Health and Human Services regarding whether each proposal meets criteria for PFPMs established by the Secretary. We have been very busy meeting since the beginning of the year as a committee, and we have established a way of a platform for evaluating proposals that will be submitted, and we are using the Secretary's criteria as the backbone for that proposal process. And so in those criteria elements, we as a committee have put emphasis on certain elements of the criteria components that we think are particularly important to drive the goals that were created when MACRA was established. So you can see we have 9 of them listed here. Scope of proposed payment model, which is high priority. Promoting quality and value, again, high priority. Flexibility for practitioners, payment methodology, high priority. Evaluation goals, integration and care coordination, patient choice, patient safety, and health information technology. By statute, the Secretary of HHS must review the comments and recommendations of PTAC and post a detailed response on the website of the Centers for Medicare and Medicaid Services. The PTAC composition is made up of 11 individuals who are appointed by the Government Accountability Office. Folks have national recognition for their expertise in physician-focused payment models and delivery of care. There are no more than 5 folks on the committee can be providers or representatives of providers. The terms of the committee members are intended to be staggered, with the first set of appointments for terms of 1, 2, or 3 years. Reappointments then will be for 3-year terms. Committee members, as I said, they can be reappointed, and the full list of PTAC members are at the link seen on this slide at the bottom. So what is a physician-focused payment model? A PFPM is an alternative payment model in which Medicare is a payer, in which eligible clinicians that are eligible professionals as defined in Section 1848K3B of the Act are participants and play a core role in implementing the APM's payment methodology, and which targets the quality and cost of services that eligible professionals participating in the alternative payment model provide, order, or can significantly influence. The PTAC goals and process. The goal is to encourage new alternative payment model options for Medicare clinicians. So the process is a submission of a model proposal by the stakeholder community. It's submitted to the Technical Advisory Committee. The 11 members go through our review process, and that process is detailed on our website. And then ultimately our deliberations, which are public. We are a FACA committee, so everything we do is transparent, and deliberations are in public. Those recommendations will then be made to the Secretary, and she or he will comment on their website regarding our recommendation for consideration and whether the model proposal is moved forward for testing or implementation. So I'm going to turn it over to my co-presenter, Elizabeth Mitchell, to talk actually about the submitting process that the committee has developed.
Thank you, Jeff. I did want to note that there are some folks who seem to be having audio difficulties. We are working on that, although I don't know if you can hear me say that, but the operator is trying to resolve any audio issues that we are having. In the meantime, I will keep going. Jeff did a great job sort of explaining sort of who we are and how we got here. And I would just add that since our first meeting in January of 2016, so we're coming up on the 1-year mark, the PTAC has been developing processes that we're going to use to evaluate submitted proposals for PFPMs. In April of 2016, we posted our first draft of the proposal review process and received comments on that. And a week ago, recently, we posted a draft on the information that we are going to be seeking from proposal submitters. Just this week, we finalized our draft of the request for proposals, and we'll be releasing that shortly. So we are hard at work making sure that these processes are transparent and available. And then we actually began receiving letters of intent on October 1st, 2016. That was a big moment for us as a committee. We have received 4 to date. I want to be really clear because we've had some confusion around this. There is no deadline for letters of intent. We accept them at any time, sort of rolling admissions, but they must be submitted at least 30 days prior to any full proposal. So you can submit it at any time, but please know that they are required 30 days prior to submitting any proposals, and they can be sent to PTAC at HHS.gov. We intend to begin accepting full proposals on December 1st, 2016, and those will be submitted through Scholar One for review, and there's details about that on the website. Next slide, please. Maybe I can advance. Next slide, thank you. So we are trying to balance several things. Our entire committee is very committed to ensuring that this is a stakeholder-friendly endeavor. We are truly seeking input from the field. This is about understanding what works and what challenges are in the field from practitioners and how payment changes may address them. So we're trying to balance several things. We want to be succinct in our instructions, but we want to make sure that we are asking for ample information and that it is clear what information is required to have a complete submission. We do want to make the submission easy. We are not asking for more information than we think will be required for an efficient process. We need sufficient details, but we also have heard from the public and understand that not all data may be available. There may not be results or measures readily available. So we want sufficient details just to enable us to efficiently evaluate the proposals that we do receive. Next slide. So with all due credit to Harold Miller for the design of these slides, our fellow committee member and PowerPoint savant, we are trying to lay out the submission timeline. As you'll see, first we ask for a letter of intent. Those are submitted through Scholar One, and those will be accepted, and you should receive a confirmation email once that is submitted. We'll assign staff from ASPE who has done an excellent job supporting the committee. We will then, as PTAC members, we will receive copies of the letters of intent, and we have also decided to share that information with CMMI so that we are trying to avoid any redundancy or duplication whenever possible. We're trying to ensure that that's an efficient process of sharing information. Our contractor will then scan the environment for any literature that may inform the evaluation of the proposal. We will come up with an additional data strategy, and we'll share that information and also seek high-level contextual information from CMMI. And then we'll begin identifying any additional expertise that we might need in that 30-day period. The next 16 weeks is dedicated to our review of the recommendation. Once it is submitted, the chair and the vice chair will assign some members of the PTAC to do an initial review. We're calling that the preliminary review team. And they will spend several weeks. We don't know yet. We haven't done it, but as efficiently but as thoroughly as possible, they will review the proposal initially, and there will be a lead reviewer assigned, and they will then make recommendations to the full PTAC committee, where we will, once we have evaluated that, we will and done our own discussion, which will be in public. All of our deliberations are in public, as Jeff mentioned. we will make a decision about whether or not the proposal is recommended, not recommended, or recommended as a high priority, and it then goes to HHS for their decision and for the Secretary's response. Next slide. This is a deeper dive into that process. Again, we want to ensure that the proposal is complete and identify the PTAC reviewers. We want to call out here that we have developed a very stringent conflict of interest policy. We want to ensure a very fair, transparent review of every proposal. Once that preliminary review team is assembled, and we will have at least a physician on every review team, they will identify questions, and at some point we may ask for revised information from the applicant. We will ensure that there is also a public comment period. And we want to hear information from other stakeholders who may have related or relevant experience. And we will address responses to questions and concerns from the applicant. Again, this is an estimated time. We will then have that report from the preliminary review team on if and how and the proposal meets our criteria, and then the discussion and decision by the PTAC. So again, that's just a sort of a more granular look at that 16-week process. Next slide. So again, this is where we are on our overall timeline. We've accepted comments on our draft processes, and we will be issuing a final proposed RFP very shortly. We will begin accepting physician-focused payment model proposals on December 1st. And we have had indications in some of our LOIs that we will receive them. We hope we will be making recommendations in the spring of 2017 on initial proposals, assuming that we have complete proposals to evaluate. And then I would say that our shared aim, I believe this is true across the committee and with CMS and CMMI, that we actually have some models in the field by the spring of 2018 that will require all of us to work very efficiently to ensure that that's possible, but we want as many providers and stakeholders as possible to be able to participate in these payment models. Next slide. So again, our priorities are ensuring our readiness for receipt of proposals on December 1. We want to ensure that data is available to those who need it. We have heard very consistently that access to needed data is a key barrier to model development and model testing. And we will be finalizing an analysis plan and scoring methodologies, and those will all be shared. Next slide. So we want your participation. Again, this is intended to be very inclusive, very transparent, really reflective of the field. We will have at least quarterly public meetings. We want public comments regularly. They are invited not only at all of our public meetings, but on all of our key documents. Please do visit our website. Follow us on Twitter. I think we're up to 30 followers. And please feel free to reach out with feedback and comments on any of our work. We truly invite and need that. So we look forward to working with all of you to really ensure that we are able to recommend models to the Secretary that really are reflective of better care at lower cost for patients.
Thank you, Elizabeth. And just wanted to make sure that everyone on the call knows that it's being recorded, and the recording will be sent to participants later today. And that includes the slides as well. So we're going to open it up for questions with the help from the operator to try and coordinate. And we also have Dr. Bob Berenson, who introduced himself at the beginning, who will help Elizabeth and I field questions from all of you.
Thank you. And ladies and gentlemen, if you'd like to register a question, please press the 1 followed by the 3, the 1 followed by the 4 on your telephone. You'll hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. If you're using a speakerphone, please lift your handset before entering your request. And as a reminder, ladies and gentlemen, please press 1-4 for questions. And
Jeff,
Dr. Bailet,
okay. Sorry, go ahead.
And we do have a question from the line of Charles Accurso with the Digestive Healthcare Center. Please proceed.
Hi, good afternoon. Thank you very much for your presentation. We appreciate the openness that you're suggesting. Do you have any suggestions in terms of what kind of things in these proposals you're looking for? For example, downside risk, prospective or retrospective models. Any suggestions on what other programs that are already established or in use that we can look for in terms of what the committee would be looking for? Thank you.
I'll start. That's a great question, and we have spent a considerable amount of time as a committee framing up what we think collectively would be important and what's out there relative to existing models that are alternative payment methodologies that seem to be working. And in our request for proposal sort of details, walks the stakeholders who are considering proposals through the kinds of elements that we would want to see in a proposal. And I'm not sure I'm answering your question specifically relative to other models that are out there. Elizabeth, Bob?
Yeah, let me jump in, if I could, to make a couple of points. We are interested in testing alternative payment models, some of which may qualify as what MACRA has identified, and CMS has given the label of advanced alternative payment models, which have specific criteria to be eligible to get the extra payment and the exception or exemption from MIPS, and that does involve having more than nominal risk, and CMS has defined that in the October 14th regulation, some requirements around use of electronic health records and quality measurement. But we will also be quite interested in alternative payment models that don't necessarily meet those criteria but are new and promising and worthy of demonstration. We anticipate in some cases that what we'll see are good ideas, but that they can be maybe accommodated with relative ease within the physician fee schedule, or perhaps as a modification to an already existing APM that's in the field being tested. So one of our jobs is actually to help the proposer sort of find the right place into what's admittedly a very complicated system. So I don't know if that helps, but I would make those points.
Thank you, Bob. We have another question.
Our next question comes from the line of Jenny Hu with the Consumer Purchaser Alliance. Please proceed.
Hi, thank you. I was wondering if there are any processes in place to ensure that HHS receives multi-stakeholder input on the proposed models.
Jeff, this is Elizabeth. I will take that. We certainly welcome multi-stakeholder input and want to be very explicit that all of our public processes are open to all stakeholders. We would invite input from employers or beneficiaries or commercial plans. We really want input from all stakeholders to ensure that the models that we are evaluating actually meet multiple aims. Again, the primary criteria is better care, improved quality, and cost either reduced or maintained. So I think that those are shared aims. Those are criteria that are laid out in the final rule, but we absolutely welcome and invite input from all stakeholders through all of our processes.
And I would just add that in a process in which largely provider groups will be, and mostly physician groups will be coming forward with proposals that representatives of consumers or employers or others can often make very useful contributions in the public comment period as to how, with some modest modification, a model can be altered to include, for example, a patient or consumer perspective. So we very much are hoping that stakeholders who don't necessarily plan to come forward with their own payment model are part of the process.
And this is Jeff, and I'm going back to the previous slide, which shows in week 3, there's a 3-week period, actually, which would be in week 6, beginning week 6, where there's a public comment period. So the proposals will be available for people to review, and the committee is very actively interested in what the stakeholder community may have to say about proposals, and that input will be included as we deliberate regarding our ultimate recommendations.
And just a couple other comments. There is nothing that would preclude a non-physician group from submitting a model, either in partnership or on their own. And also, one of the information items that we will be looking for when we do release the final RFP is if and how this will work with other commercial payers. So it will clearly be important to us to understand that commercial perspective.
Great, thank you.
Ladies and gentlemen, as a reminder to register for a question, please press 1-4 on your telephone keypad.
If it's okay, I just saw a question in the chat box as well, just to clarify if this is a, quote, rolling submission process. The answer is yes. There is no end date on when submissions will be accepted. We just have a start date of December 1st. So, but there's no deadline per se.
To that point, Elizabeth, I also see another question relative to who. Do we have a sense from CMS who's going to be handling the recommendations? That'll be CMMI. Will be working with the Secretary once our recommendations are considered. When we have talked with CMMI relative to their process, once our recommendation, if our recommendation is accepted by the Secretary, from their sort of guesstimate on a timeline, if we can make recommendations in April or so of 2017, they're hoping that their systems and processes would allow for that proposal to be implemented the beginning of 2018. So we're certainly not holding CMS to that timeline, but as we've talked with them, that is their desire. If we can get a recommendation out in the spring, that they could get it online and implemented by January or so of 2018.
And while we're waiting for another question, maybe this is an opportunity that I have to jump in with what may be on some people's minds. It was certainly on my mind as I accepted the invitation to join the PTAC, which is, are we just a redundant committee that's going to just sort of delay by X number of months the Innovation Center's consideration of a proposal? And then I've come to the conclusion that is not the case. In fact, as I was thinking about that issue, I remembered that when I was at CMS for 3 years in a senior position, I actually co-chaired a FACA advisory committee. And it was a very important committee that CMS took very seriously. The committee and CMS staff developed a good working relationship, and yet we were independent. So one of the challenges here is that the PTAC needs to maintain its independence as Congress envisioned, and at the same time develop a good working relationship in collaboration with with CMMI, and I think we've made some great progress along those lines. And the clear advantage of a PTAC is to have a different set of eyes looking at potential proposals with sort of a range of perspectives. We actually have 7 out of the 11 members of the PTAC were practicing physicians. Not all of us are currently, and that does permit a consideration of ideas and the potential for seeing value or seeing how the design could be altered in such a way that maybe CMMI hadn't considered themselves. So as I've now spent a year doing this, I see the real value and the reality that we are developing a good working relationship with the key staff at CMMI.
And we do have another question on the line, from the line of Barbara Tamar with the ACEP. Please proceed.
Thank you. I'm with the emergency physicians, and we are very interested in moving in this direction. You see over 130 million patients a year, but we only have a small piece of those, so we have sort of fallen out of the various other models and the payment modifier for attribution purposes. We've developed 3 models now conceptually, and now we're sort of challenged by how much resources do we expend to access data to sort of test them internally before we come to the PTAC. And I might add that optimally we realize that CMS and probably the PTAC as well is not looking for sort of 1,000 tiny APMs to bloom out there by specialty, and we realize we can do a lot better by linking, particularly with an ACO or a group like that is already organized and maybe taking risk already to add some value. But I guess my question is, when is too early, or when can you come to the PTAC to get advice on what to do next without expending just a tremendous amount of time and resources?
Well, so the PTAC hosts public meetings on a regular basis. We've had 3 so far.
Right.
And during those meetings, stakeholders have come forward and asked questions. And so that is a forum. There's also some stakeholders have actually sent the PTAC letters of inquiry, which we have then offline we've answered to try and provide input and guidance. So I think those are just two potential ways of getting the kind of insight that I think you're looking for as you think about potentially developing a model for consideration.
Thank you.
This is Elizabeth. We have heard from several stakeholders that technical assistance and data may be necessary for them to fully develop their proposals. We have heard that. We are trying to assess what we could offer. We have some strong support from contractors, but have to scale that also to sort of the number of proposals that we anticipate. So we are trying to determine now what and how much we'll be able to offer submitters, and sort of at what level of readiness would we hope to see a proposal. So we have heard that request. If you have thoughts on that, we welcome any sort of communication about that, but we are trying to evaluate that, and we will clarify and communicate that as it becomes clear.
Thank you.
There was a question on the chat about the RFP, our RFP process. When is that going to become public, our final document? And that is going to be published shortly on our website. Operator, are there additional questions?
And please press 1 for questions. Dr. Bailet, I'm showing no further questions at this time. I will turn the call back to you.
Great. Well, I want to thank everyone. We had over 97 participants on the webinar today. We appreciate everybody's active involvement and engagement in this process. I don't think we can say it enough. The committee welcomes stakeholder feedback. We actually really consider, if you look at our processes and our products, they are heavily influenced by the stakeholder community. We want to be completely transparent, and we will continue this process going forward and welcome feedback, suggestions at any time. So I'm going to go ahead and conclude the webinar for today, and again want to thank everyone for their participation. Thank you.
Ladies and gentlemen, that does conclude the conference call for today. We thank you for your participation and ask that you please disconnect your lines.